Hello everyone. We're talking about gut tube and body cavities, and I'm your presenter, Sannan Rehman. We've talked about a lot about the body wall, the lateral plate mesoderm, how the development occurs, the days, the duration, how ventral body wall is formed. Now let's take a look at the clinical correlates of what happens if you do not if the process does not take place as it is supposed to be. I hope you remember how the process took place. That would help you to understand these anomalies way better. In this topic, we'll be talking about ectopia cordis and gastroschisis, bladder and cloacal exstrophy, and we'll compare omphalocele with gastroschisis. Okay, so ventral body wall defect. How was the ventral body wall being formed? Ventral body wall was being formed by ventral body wall folds which were formed by parietal layer of the lateral plate mesoderm along with overlying ectoderm and cells from the somites. Now, ventral body wall defects can occur in three regions. If they occur in the thoracic region, it can cause ectopia cordis. If they occur in the abdominal region, it can cause gastroschisis. If they occur in the pelvic region, it can cause bladder or cloacal exstrophy. Defect is due to the failure of closure of the ventral body wall. It usually involves the lateral body folds. Omphalocele is the failure of gut to return to the body cavity after physiological herniation. Physiological herniation usually takes place between 6th and 10th weeks of development because there is not enough space in the gut tube to accommodate all of the gut contents. At 10th week of development, it is supposed to come back because the gut cavity has increased in size and can accommodate all of the gut tube. However, when it fails to occur, omphalocele takes place. Now, let's take a look at ectopia cordis. Ectopia cordis is due to the failure of closure of the lateral body folds in the thoracic region. What happens is heart lies outside the body. Here you can see in the figure the heart is lying outside the body. Occurs as a part of central pentology. It can also occur alone. The defect in central pentology only, the defect extends from the caudal end of the sternum. What was caudal? Cranial is towards the head, caudal is towards the feet. The caudal end of the sternum and extends into the upper abdomen. So let's talk about central pentology. Pentology means 5, so we have 5 elements in central pentology. First, we have ectopia cordis, that is failure of fusion of the ventral body wall folds in the thoracic region cause the heart to bulge out of the body. Then we have defects in the anterior region of the diaphragm, obviously due to defects in the lateral body wall folds. There may be absence of diaphragm. Then defects in the sternum, obviously again due to lateral body wall fold defects and abdominal wall defects, which may be either omphalocele and gastroschisis. Omphalocele was a failure of the physiologically herniated gut tubes to go back into the body cavity after 10th week of development, and gastroschisis is the failure of lateral body wall fold fusion in the abdominal region. Here, gastroschisis, it occurs when the ventral abdominal wall folds fail to close in the abdominal region. Thoracic region, when it was happening in the thoracic region, we had ectopia cordis. When it occurs in the abdominal region, we have gastroschisis. So intestinal loops here, it is very evident. Intestinal loops herniate into the amniotic cavity through the defect. So the intestinal loops are herniating naked into the amniotic cavity. It lies mostly to the right of the umbilicus. You can see that here. There is a rise in its incidence for some reason, the cause of which is not known yet. It is mostly seen in infants of thin mothers who are less than 20 years of age, so decreased maternal age, or a very young mother may have a child with gastroschisis. It can be detected by ultrasonography, and elevated alpha-fetoprotein in maternal serum and amniotic fluid are found. It is not associated with any chromosomal abnormalities. So now let's talk about bladder and cloacal exstrophy. So there is abnormal body wall closure in the pelvic region. Now, when it was abnormal closure in thoracic region, we had ectopia cordis. When it was abnormal body closure in the abdominal region, we had gastroschisis. Now we have abnormal ventral body wall closure in the pelvic region, the result of which is bladder and or cloacal exstrophy. Bladder exstrophy represents a less severe defect. That is, the defect appears later, it is less severe. In males, penis may be involved. It is usually seen in epispadias, is commonly seen. Cloacal exstrophy represents a more severe wall closure failure in the pelvic region. That means the defect occurred early on during development and cloacal exstrophy happened. It is much more severe than the bladder exstrophy alone. Both bladder and the rectum are exposed. In the figure, you can clearly see these are the halves of the bladder and these are the coils of intestine, both of which are being exposed. Now, we'll compare omphalocele versus gastroschisis. So, first of all, gastroschisis, then omphalocele. It's very evident from the figure. Always keep in mind this figure, you'll be able to make out gastroschisis and omphalocele very easily. So gastroschisis is due to the failure of body wall defects. We discussed it previously. When there is failure of the ventral body wall defect in the abdominal region, then gastroschisis occur. Omphalocele, the cause is not the same. In omphalocele, there's failure of gut loops to return from physiological hernia. The physiological hernia that was occurring because the gut cavity could not accommodate the gut loop, the developing gut loops that herniated into the umbilical cord. Now they were supposed to come back, but they did not. Gut loops, in gastroschisis, the gut loops are dangling in the amniotic cavity naked. They're not covered by any membrane. However, in omphalocele, as it is evident by the figure, in the diagram, you can clearly see the gut loops are covered by amnion. So, gastroschisis is not associated with chromosomal abnormalities, while omphalocele is usually associated with severe chromosomal abnormalities. It can occur as a part of Cantrell pathology. Omphalocele has a high mortality and severe cardiac malformation, and neural tube defects may be seen because it has chromosomal abnormalities. So multiple defects can be happening at the same time. Gastroschisis usually occur to the right of umbilicus, a very important diagnostic point. It usually occurs to the right of the umbilicus. However, omphalocele always occurs in the midline. Gastroschisis may or may not occur to the right of the umbilicus, but omphalocele would always be in the midline, would be covered by this amnion. That is the diagnostic point, and it is very important for you to remember. This was all about this section, the clinical section of the developmental aspects of this body tube. It was a very important section, and the comparison between gastroschisis and omphalocele is a typical question that usually appears in your exams, in your vivas. in your talks, in your bedside. You'll see a lot of patients with these conditions. You may or may not see them depending upon where you practice, but it is very important. It is a these things can be prevented. So you should have a clear background of how these things occur and how to prevent them and how to treat them. For further details, please keep watching sqadia.com.